Welcome to echocardiography lecture series. Right ventricle and right atrium chamber quantification is less complex than the left side ones. However, they are as important. Join me to this short lecture about the right side chamber quantification. So let's begin. This lecture is about the right side chamber quantification. We're going to learn about the RV size and function as well as the right atrial size. In RV size measurement, we can use the linear method and the volumetric method. In linear method, we draw lines and we measure it. In volumetric, it is by calculating the volume. In RV linear measurements, let's say in the apical 4-chamber view, we have a few measurements here that we can do. One of them is the RV internal dimension in diastole at the base and mid-level. We can measure it from inside to inside at end diastole or the largest RV size. However, because the RV is a complex structure, it engulfs the LV as you can see here, and little bit tilting or angling of the probe can result in different RV size. So in order to unify all these sizes and to have it more reproducible, we have to measure it in something called the RV focused view. RV focused view is obtained by having the LV apex near the probe. So the probe is in the center of the LV, and then tilting anterior and posterior to get the maximum RV size. Here, the maximum RV size, we call it the RV focus view, and it is the standard view to measure RV size in the apical 4-chamber view. Also, utilizing the same view, we can measure the RV area. The RV area, when measured, it should be measured from the tricuspid annulus all the way to the apex. We need to make sure that we exclude all those trabeculation and moderator band if it is there. Another way to measure RV is in parasternal long axis. We measure the RV OT, the RV outflow tract in parasternal long axis, because we have different RV OT measurements. So this one is parasternal long axis, and we measure it between the aorta and the septum. So this is the aorta and this is the septum. So at the aortoseptal junction from here, we draw a perpendicular line all the way to the RV free wall here, inner edge to inner edge at end of diastole, where the RV is at its largest diameter. In parasternal short axis, at the level of aorta, so you have to see the aortic valve here. So we have few measurements we can do here. The RVOT proximal, it's not the RVOT plaques, it's the proximal. We measure it, as you can see here, perpendicular to the aortic valve all the way to the RV free wall here, inner edge to inner edge, and we measure it at end of diastole. Also, we have the RVOT distal, just proximal to the pulmonic valve. So this is the pulmonic valve here, just proximal to that. We measure the RVOT distal in a similar fashion. So before we leave the linear measurements, we have to talk about the RV wall thickness measurements, because it will determine whether the RV is hypertrophied or not. And the way to measure it is again by a linear method. It can be measured in parasternal long axis. However, in the subcostal view, or the subcostal view is the preferred view. And the way to measure it is you have to be careful to exclude any pericardial fat or thickened pericardium, as well as any trabeculation, and measure it at a level distant from the annulus around the same distance of this tricuspid valve leaflet, just on the side of it, in a perpendicular fashion to the wall, like this. So this is how we measure the RV wall thickness. Those are the normal values for the RV linear measurements we talked about. The RV internal dimension and diastole basal level, mid-level, the RVOT in parasternal long axis, and the proximal from short axis, and distal from short axis. Also the RV wall thickness, it's up to 5 millimeter. Anything more than this indicates RV hypertrophy, and the area for men and area for women in the apical 4-chamber view. Now proceeding to volumetric measurement of the RV. As you can see, 3D, this is 3D measurement of the RV. So 3D echocardiography is the only echocardiographic modality that allows measurement of the RV volume. Because as we saw that the RV is a complex shape, and assuming a fixed geometrical shape is impossible. However, 3D for the RV is a little bit challenging and requires experience. These are the normal values here for the RV volume obtained in 3D. Now, after we finish the RV size and wall thickness, it's time to talk about the RV systolic function. In order to determine the RV systolic function, we have many tools. One of them, the TAPSE, which is tricuspid annulus planar systolic excursion, or the FAC, or fractional area change, tissue Doppler, which is the same as S prime, and the RV index of myocardial performance. TAPSE is one of the most common way to determine the RV systolic function. We measure TAPSE by measuring how far the lateral annulus, the tricuspid lateral annulus, traveled during systole. So this is the lateral annulus here, and let's assume it traveled all the way to this point. So we measure this distance of travel. We do this by aligning our M-mode cursor along the pathway of this lateral annulus. So let's assume if the lateral annulus is somewhere here and traveled like this, we have to align our M-mode cursor along the direction of this lateral annulus, and we plot it in M-mode here. The way to measure it is we measure a vertical line between this diastolic position of the annulus and all the way to the systolic position of the annulus. It's a vertical line, so we measure the distance from here to here, like this. The normal value is 17 and more. So it's more or equal 17 is considered normal. It is true that TAPSE will measure the longitudinal function of the RV. However, it correlates very well with the global systolic function of the RV. Another way of determining RV systolic function is the fractional area change, which is defined as percentage of the area change of the RV from end of diastole till the end of systole. And it's measured by measuring the RV area in the apical 4-chamber view, the RV focus view that we described earlier, and end of diastole and end of systole. And this is the equation. So the difference between area 1, which is end of diastole, the largest area, and area 2, which is end of systole, divided by the end diastolic area times 100. The normal is 35% and more. So normal is more than 35%. We can also estimate the RV systolic function by utilizing the tissue Doppler and measuring this lateral annular systolic velocity. So we put our sample volume here in the lateral annulus of tricuspid, and we measure S prime, which is the systolic velocity. The normal is 9.5 and more centimeter per second. Similar to LV, also we can use or we can measure the index of myocardial performance, and it is defined at the ratio of isovolumic time, this time where there is no volume going up or down, so this time, to the ejection time. So this time plus this time divided by the total ejection time. So RIMP can be obtained either by pulse Doppler or a tissue Doppler. In pulse wave Doppler method, two signals have to be obtained at different places, the RVOT and the RV inflow. It's unlike the one we get from LV myocardial performance index, which we can do it in the same beat. However, in RV we cannot do that. The other way to do it is from tissue Doppler. In tissue Doppler, however, we can use it, or we can utilize this method in a single beat. So it is the preferred way to measure it. And the way to measure it is as seen here. This is the E wave, this is all E wave and A wave. And just when this A wave meets the baseline here, now isovolumic contraction time starts, this until here. And then we will have the ejection time. This is the ejection time, where we have ejection going all the way to the RV side and comes back. Then we have the isovolumic relaxation. So after this ejection meets the baseline, we have the isovolumic relaxation time, and then an E wave starts here. So this is IVRT, this is IVCT, which is isovolumic contraction time. So it's IVCT plus IVRT divided by the ejection time. Also, RV strain is feasible. We can always use the RV strain for more accurate RV systolic function. It's a bit time consuming, but it's still doable. Sometimes if the software does not have the package for the RV, we still can do it by utilizing the LV package. And then what we are interested in here is this RV free wall, because the septum was already taken in the LV evaluation. So what we need to trace here is the RV free wall. So we put our cursor here, our region of interest on the RV free wall. The normal is minus 20% and less. So minus 21% is also normal, but minus 19% is a little bit abnormal. The last method to estimate the RV systolic function is ejection fraction, and the only way to do ejection fraction in the RV, because it has a complex geometric shape, is 3D and 3D only. So we need to have a 3D software. It's a little bit time consuming and needs experience. However, it is accurate. The normal RV ejection fraction is 45% and more. In this table, we will see the RV systolic function parameters here and the abnormal value, or the cutoff value for abnormal systolic function here. Now we have to say something about the hepatic vein. It is similar to the pulmonic vein or pulmonary vein on the left side. The hepatic vein has a similar waveform on the right side. First of all, how to do it? It's measured, or it's pulsed by pulse wave Doppler in the subcostal image, and then we put a color Doppler to identify the hepatic vein here. Then we put our sample volume within this hepatic vein. We will have a forward flow toward the RA, forward systolic flow, so we call it S during systole. We have a diastolic flow, also forward flow, and similar to the pulmonary vein, we have this atrial reversal after the P wave here. Sometimes an overfilling of the RA will give us this systolic reversal. We call it a V wave or systolic reversal, which is completely normal. It's no big deal. So normal hepatic venous pattern is similar to the pulmonary, is S more than D. Sometimes if we have increase in RA pressure, we have systolic blunting where the S is less than the D. Also, if we have, we will see this in valvular heart disease, when we have severe tricuspid regurgitation, we might have systolic reversal. So this S wave will be going toward the hepatic venous side instead of going to the RA side. Having that said, now we can proceed to RV diastolic function. RV diastolic function assessment is not part of routine echocardiographic study. However, it is useful sometimes to explain some of the phenomena or abnormal phenomena that we see. For example, a flattened interventricular septum during diastole, and we don't have a lot of tricuspid regurg or pulmonary regurg, so no volume overload. So it can be RV diastolic dysfunction or bad RV diastolic function. So similar to the left side, we have to measure few parameters, including the E and A, tricuspid E and A, again measured at the tips of the valve during diastole. However, the problem with this right-sided E and A, it differs a lot with inspiration and expiration. This is why it has to be measured at end of expiration, or we average 5 beats. The other parameters are the lateral annulus E prime and A prime. We don't measure the septum because it's part of the LV. Another parameter is hepatic venous flow. It's a routine to be measured in all the studies. Also the RA size. So we have grade 1, 2, and 3, similar to the left side. In grade 1, it's impaired relaxation. We will have E and A ratio less than 0.8. Pseudonormal, where the RA now pressure starts to become elevated. Now we have dilated RA. The EA ratio is between 0.8 and 2.1. And E over E prime is more than 6. And or also diastolic flow predominance. So S smaller than the D. Restrictive pattern, E over A ratio is more than 2.1. Also we can see E wave deceleration time less than 120. So it will look steep. And of course dilated right atrium. Finally, the right atrial size. The RA size is measured in apical 4-chamber, but not any apical 4-chamber. It's similar to RV focused, where we will have the LV apex on the view, on top of the view here near the probe. But this time we have to do something called RA focused, where we tilt the probe until we get the maximum or the largest RA size while the LV apex is still in focus or under the probe. Then we measure it only by volume. We trace it from the annulus, tricuspid annulus, and then we measure it using Simpson, and we only measure one plane utilizing this method. We have different parameters for women and men, unlike the LA size where it's unified between men and women, but in RA size we have different normal values. Thank you for watching. I hope you enjoyed this lecture. My next talk is my favorite, and it's about hemodynamics.